Greetings everyone, this is Dilip and welcome to another episode of DrDilipsMMS Weekly. So this was yesterday's question and this question is all about ARDS. So I'm not only going to discuss the New Berlin definition or criteria for ARDS, I'm going to discuss some few more information on ARDS. First of all, dissect what really ARDS is. So let us take the word ARDS. And you can see from the word ARDS, you can see that first of all, it's an acute respiratory distress syndrome. So what could be the definition of acute? So, uh, it means, you should develop a new onset respiratory distress within 7 days from the point of insult. So for example, let me take an insult. So there will be some primary insult to the lung. So from the time of insult, if you develop a respiratory distress, or a syndrome of respiratory distress within 7 days from the point of insult. So that is what we generally call it as acute according to New Berlin definition. So for information, New Berlin definition was given in 2012. This is the latest that we have. And this is what we define as acute. So second thing, there are certain features of a respiratory distress syndrome. So second thing, what you have to know is a chest X-ray or a CT, or generally you can take it as an imaging technique, a chest imaging technique, a chest X-ray or a CT, which is showing bilateral infiltrates. So this bilateral infiltrates, not always, not a definitive criteria, but still it is very likely symmetric and probably, very likely its location will be in the perihilar region. So that's what you're going to get in the chest X-ray or the CT. So for understanding this, we can see an image. So which is one of our patient's image who developed ARDS let me tell you a short history of this patient. This X-ray is definitely of an ARDS X-ray. So this patient basically developed sepsis. The reason for sepsis is ascending cholangitis. Why she developed ascending cholangitis? She was a known case of primary sclerosing cholangitis. Because of this is a high risk factor for ascending cholangitis, and because of the ascending cholangitis, she developed sepsis. And when she developed sepsis, around day 2, day 3, she developed severe respiratory distress in the ward. So we shifted to the ICU, and this was the X-ray taken on day 3, or I think around day 3. So what you can clearly see, this is almost symmetric, and you can see predominantly the majority of the infiltrates are located in the perihilar region. For your information, even a cardiogenic pulmonary edema tends to be in the perihilar region. So this is not a cardiogenic pulmonary edema. So, that's actually one of the very important differentials for ARDS. So this ARDS by definition is a non-cardiogenic pulmonary edema. So you have to differentiate from a cardiogenic pulmonary edema and a non-cardiogenic pulmonary edema. So here, this is a bilateral symmetric infiltrates in a patient who has developed sepsis. So I'm going to concretely diagnose this patient as ARDS. So number 2, so it's imaging. So it's going to show a bilateral symmetric infiltrates. Number 3, so third definition. So first one is acute, second one is imaging, and third one. So let us see the third definition. Third definition, I told you it's a, you're going to get a pulmonary edema in ARDS. So, but what is this pulmonary edema? This pulmonary edema is non-hydrostatic. It should not be hydrostatic edema. So what is hydrostatic? Whenever the moment I call hydrostatic, it's due to stasis of the blood in the pulmonary circulation. So which is by rule of thumb, we take any hydrostatic edemas as cardiogenic edemas. So this is generally a non-hydrostatic, which means it should be, or it is a non-cardiogenic pulmonary edema. So how can you prove that it's a non-cardiogenic pulmonary edema? According to the old Berlin criteria. So this should be proved with the pulmonary capillary wedge pressure as, of less than or equal to 18 millimeters of mercury. But even what is pulmonary capillary wedge pressure? It's going to be synonymous with your left atrial pressure. So PCWP can be easily measured with the help of right heart catheterization, which is actually the gold standard for measuring PCWP. So whenever you have an elevated left atrial pressure, the usual cause of elevated left atrial pressure is going to be the left ventricular failure. So it's cardiogenic pulmonary edema. So whenever you tell the PCWP less than or equal to 18, in a patient who is having pulmonary edema, you can clearly tell the pulmonary edema is not due to cardiac failure or elevated left atrial pressures, which is nothing but a non-cardiogenic or a non-hydrostatic pulmonary edema. That's what I'm going to tell. So the next thing, but this is the old criteria for your information. According to the New Berlin definition, this PCWP of less than or equal to 18 is no longer required according to the New Berlin definition. Why this PCWP has been removed is because whenever the patient is critically ill, let's say even when I was working in critical care, in 2012 or 13 during that time. So what we tend to do is routinely, many patients we tend to insert a catheter called Swan-Ganz catheter. That is the gold standard for right heart catheterization. So we introduce a Swan-Ganz for everyone. So, but actually a lot of articles which came and in our institution we did like our own article as well, our own study as well. So which clearly proved that routine right heart catheterization is not beneficial. And also like some to in worst case scenario, certain trials have proven that routine right heart catheterization may be even harmful and increases mortality. So that is why we never do this. And according to that, your Berlin criteria also has to be adjusted. So that's why in 2012 they removed this PCWP less than or equal to 18 as one of the criteria for ARDS. And the new Berlin definition states that like the pulmonary edema what you're seeing should not be fully explained by cardiac failure. So, like it is not explained by cardiac failure. So maybe there are a lot of various ways to see non-invasively, but that's a topic for a different day. But still, like your pulmonary edema should not be explained by cardiac failure. So that's a new definition. So PCWP less than or equal to 18 is not needed for diagnosing ARDS. So that is the reason why if you can see in this, like this second thing, I can clearly tell it is wrong. So this is not needed for diagnosing ARDS. So next, let us analyze the fourth point. Now, there are four definitions for, four for strategies for diagnosing ARDS. So let us see the fourth one for diagnosing, a fourth point for diagnosing ARDS according to New Berlin definition. The fourth one is nothing but the PaO to FaO2 ratio. So which should be less than 300. Like according to the old Berlin definition, the PaO to FaO2 ratio based on that. So if it is in the range of 200 to 300, they called it as something called acute lung injury, and if it is less than 200, they called it as ARDS. And again, what is the importance of this? This is completely abandoned. So the new Berlin criteria totally abandoned the terminology called acute lung injury, and there is nothing called acute lung injury. So according to new Berlin definition, any PaO to FaO2 ratio of less than 300 is going to be ARDS. And not only this, along with this PO to FaO2 ratio of less than 300, you should have a PEEP of more than or equal to 5 centimeter of water. So then only you can diagnose ARDS. That is according to the definition. So why they added this definition? Because many cases, like in the past decade, has been diagnosed as ARDS. Actually, you don't have like ARDS in those patients. So why? Because like whenever you have an ARDS, there will be severe lung injury, and let us see the mechanisms of severe lung injury in a meanwhile. So they are going to have a very severe lung injury and a lot of like atelectatic and collapsed alveoli you're going to see, and it's very difficult to open up those alveoli unless and until you give a positive end expiratory pressure. So that is the reason why like many patients has been falsely diagnosed, because if the patient is on mask nasal cannula 4 liters per minute or 6 liters per minute, and if he's maintaining the oxygenation adequately, and I'm damn sure he's not having ARDS. So ARDS poses a great challenge for like adequate oxygenation no matter what you do. So the saturation is not going to pick up that easily. So that is why this PEEP of 5 centimeter of water minimum has been added as a criteria for the new Berlin definition of ARDS. So that is why, let us see the analyze the question again. So that is the reason why like PO to FaO2 ratio like less than or equal to like 300 is a part of definition of acute lung injury is wrong statement. It's not at all correct. So next, let us see PEEP. Yes, it's right. PEEP of 5 centimeter of water is definitely like required for the diagnosis of ARDS. Yes, it's a right statement. So like PO to FaO2 ratio of less than 200 is called severe ARDS. Again, this is a wrong statement. So why it's going to be a wrong statement? So let us see. So according to the new Berlin definition, again they have proposed a model for severity of ARDS also. According to that, the mild ARDS, you can actually define it as PO to FaO2 ratio of somewhere between 200 to 300. So somewhere between 200 to 300 you can call it as mild ARDS, and somewhere between 100 to 200 you can call it as moderate ARDS, and anything less than 100 you can actually call it as severe ARDS. So that's it. So these are the four basic definitions of ARDS. So that is why I told C is right. So let us see, have an overview. So number one, it should be acute. Number two, you should have a bilateral infiltration chest X-ray, which is very likely symmetric and very likely perihilar in location. And number three, you have a pulmonary edema, which is non-cardiogenic, non-hydrostatic, which is not fully explained by cardiac failure, and PCWP of less than or equal to 18 is not required according to the new Berlin definition. And number four, a PaO2 FaO2 ratio of less than 300. And the current terminologies, current Berlin definition has abandoned a terminology called acute lung injury. And there are again based on the PaO2 FaO2 ratio, you can quantify the severity of ARDS. Like for example, 200 to 300 you can call mild ARDS, 300 to 200 you can call moderate ARDS, and less than 100 you can call it as severe ARDS. So why this ARDS poses a huge challenge? So before going that, let us see what are the causes of ARDS. So generally, causes of ARDS can be divided into pulmonary causes, and I can even divide into extrapulmonary causes. So we generally, in short synonym, we call it as pulmonary ARDS or extrapulmonary ARDS. So why this is important? Let me tell you. So first, what are the pulmonary cause of ARDS? So I can tell pulmonary cause of ARDS may be pneumonia first of all. So one of the important pulmonary cause of ARDS. This pneumonia can be bacterial, viral. Like in the recent swine flu epidemic, I saw a lot of cases of like pulmonary ARDS, like swine flu and H1N1 virus induced ARDS. So it could be anything. It even could be fungal also. So next is aspiration pneumonia. Again, it's a type of pneumonia, but you can keep it as separate because this aspiration pneumonitis induced ARDS tends to have excellent prognosis, very good prognosis. So that is why like this classification is very important. And next thing, like you can get in pulmonary contusion. So you injure the lungs by any means. Next thing you can get with some toxic gas inhalation, toxin inhalation, or like inhalational injury. So some toxic you have inhaled. So next you can get it fat embolia also, which is pretty common in long bone fractures. So next, what are the causes of extrapulmonary ARDS? One of the important causes of extrapulmonary ARDS is sepsis, because sepsis is actually quite the most common cause of ARDS overall as well. And like sepsis portends a very poor prognosis generally, in general sepsis, because many of the septic patients are going to have acute kidney injury as well, and multi-organ dysfunction is very common, and the prognosis of ARDS depends on the number of organs that have failed. So one organ failure, okay prognosis; two organ failure, poor prognosis; three organ or more than that, it's going to be extremely poor prognosis. Since sepsis has a tendency to cause multi-organ dysfunction, so the associated ARDS is going to have an extremely poor prognosis. And next thing, you can get a trauma, severe trauma, especially to the chest. So with or without pulmonary contusion, you can get a trauma. So the trauma is an extrapulmonary cause, and you can get in probably an acute pancreatitis, which is going to inflict a severe systemic inflammatory response syndrome. So which is again a cause of extrapulmonary ARDS, and many cases of cardiopulmonary bypass, we do see ARDS. So cardiopulmonary bypass is generally another cause of extrapulmonary ARDS, and very rarely it could be drug induced. Certain drugs can induce ARDS, and very pretty rarely. And these are the cause of extrapulmonary ARDS. Why this classification, first of all, is important into a pulmonary ARDS and extrapulmonary ARDS? Because in general, this extrapulmonary ARDS tends to be in chest X-ray and a CT. If you see, especially in a CT, you're going to get more ground glass opacities. Typically it will be relatively more ground glass opacities, and also this extrapulmonary ARDS tends to be more PEEP responsive. So that's why this distinction into like pulmonary and extrapulmonary is relatively important. Not that important, but relatively important. So let us see the other things about ARDS. So ARDS patients are like actually prone for severe lung injury and ventilator induced lung injury especially. So why they are prone for this phenomenon? So first of all, you have to understand what is ARDS. So if you take an alveoli, basically, so like the main problem with this ARDS is endothelial injury. So let me draw the capillaries here. So you're going to get a serious endothelial injury here. So by any cause, maybe due to sepsis. Sepsis can introduce a lot of cytokine storm which can damage endothelium, or the endotoxin itself can damage endothelium. So that's why it's called an endotoxin. And like it's going to cause severe endothelial injury by any means. So there is going to be massive flux of like inflammatory mediators. So massive flux of inflammatory mediators, so which is going to damage the alveoli very severely. So there is going to be diffuse cellular damage. That's what we call that. So the first preceding mechanism is endothelial injury. So followed by like this inflammatory mediator, especially this, if you analyze the I told you it's a non-hydrostatic edema, but if you take the edema fluid analyze, it's going to contain a lot of neutrophils in those. So they're going to be rapid neutrophil influx, which is going to release a lot of inflammatory mediators and it's going to cause diffuse alveolar damage. So since alveolar membrane is very, very basic essence of gas exchange, so O2 and CO2, it's a basic essence of gas exchange because of severe, damage to the alveoli, you're going to lose oxygenation first. So you're going to have very little oxygenation. So that's why your PO2 is going to reduce drastically. Like this oxygen only when it enters the blood, you're going to this oxygen only if it's going to enter the blood, you're going to get adequate partial pressure of oxygen in the artery. So if it's not going to happen, you're going to have very poor PO2 compared to the FAO2 you're delivering. That's why your PO2 FAO2 ratio is going to drop dramatically. And second thing that is going to happen in ARDS is a phenomenon called alveolar collapse. So alveolar collapse, like if you want to be a little bit posh, like you have to call this alveolar collapse as something called alveolar de-recruitment. Let us talk about that in some time. So what is alveolar de-recruitment? So this alveolar collapse is what is going to happen. So why there is alveolar collapse? Number one, I clearly told you, like this is a non-hydrostatic edema. Still, it's an edema. It's going to have a little bit of fluid and water into that. So this water is going to increase the surface tension dramatically. And second thing, there is like even though the surface tension increases with influx of water, you might escape with the surfactant production, but still here there is a diffuse alveolar damage, which is going to result in severe loss of pneumocytes, and that's going to reduce the amount of surfactant as well. So combined together, both of them are going to result in like a severe and dramatic alveolar collapse. So even though like this alveolar collapse, you might think it might be symmetric on both the lungs. Actually, it's not quite symmetric. And it's more on dependent areas. So let us see what are dependent areas. So first of all, if you take a patient who's lying on the bed, so let us see this is the thorax and maybe the limb. Sorry for the very bad diagram, but still we can clearly see that these are the dependent zones. So dependent areas of the lungs when the patient is in supine position. So these areas are going to be under high pressure. Why? Because the weight of the lung is going to act on itself, and a lot of, even though it's a fluid still, it's a non-hydrostatic edema, but still it's a edema fluid, right? So it's going to be pulling out of, out of gravity, it's going to be pulling out in the dependent areas only. So this is going to have highest amount of alveolar collapse. So especially the dependent areas are the ones that are predominantly affected in ARDS, and to a little extent even non-dependent areas are also affected, but still predominantly affected is the dependent zone. So that is the strategy. So the first strategy in ARDS is, you have to improve this oxygenation. So how will you improve the oxygenation? By increasing FaO2. So obviously you are going to increase FaO2. The initial starting FaO2 in ARDS is usually 100%. Definitely we are going to increase the FaO2 because only if you increase the FaO2 your PO2 is going to increase. So that is how you are going to oxygenate the blood. So next important thing is you have to recruit back the collapsed alveoli, or in other words, you have to open up this alveolus, or you have to open up this alveoli, which is actually we call it as alveolar recruitment. So this is very, very important. So how will you open up this collapsed alveoli? By giving a positive pressure. That's what we call it as positive end expiratory pressure. That's what we call it as PEEP. So what is the basic idea of PEEP? How it works? So let us see the compliance for that matter. So the compliance curve. So let us take pressure in the x-axis and volume of the lung in y-axis. What is compliance? Compliance is determined by something called a unit change in volume when a unit change in pressure is applied. So when you apply a pressure, how much the volume changes, that's what you're going to call it as compliance. So lung behaves a little bit weirdly. It's not a a smooth linear curve. It doesn't behave like this, by the way. So it's not like for every unit pressure you apply, it's going to smoothly inflate. It's definitely not like that. So let us rub this off. So what you're going to see in the lung is something very weird. So initial part is going to be very tough. After some time, it's going to be relatively easy. So the amount of pressure you apply the lung is going to inflate very smoothly. At a later part, it's again is going to become flat. So it's going to be increasingly difficult to increase the volume after a certain point. So this point is what we call lower inflection point, and this point we call it as upper inflection point. So there are 2 points. So below the lower inflection point, it's going to be very tough to inflate the lung, and above the upper inflection point, it's going to be again very tough to inflate the lung. So the lung can be ideally inflated very smoothly and very easily, near the and between the 2 upper and lower inflection points. So this curve is typical of an inspiratory curve. That's what I'm going to talk about. So why it's actually difficult? So if you ask me the reason, the initial portion actually you have a lot of surface tension in the alveoli. So to overcome the surface tension, you need a lot of pressure. So once the surface tension is broken at the lower inflection point, your like enlargement of the alveoli, expansion of the alveoli is going to be smooth, or distension of the alveoli is going to be smooth. And once the alveoli reaches a maximum volume, after that again it's going to be very tough. Everything has a limit, isn't it? So it's going to be very tough after this point. And you can see that between the upper and the lower inflection point, actually it is easy to inflate the lung. So that is why at this point we can tell the compliance is very high. So because for a unit change in pressure, the unit change in volume is very high between the upper and lower inflection point. That is why this point is actually quite, this area between LIP and UIP is quite important, because the compliance of the lung. And let me draw the expiratory curve as well. So how does the expiratory curve behave? So the expiratory curve is going to be something like this. It's going to be very different. So it's going to be something like this. So actually this curve has so much of importance. This is what I'm going to call it as expiratory curve. This curve is going to have pretty much a lot of importance. So let us see once I'm going to discuss about the treatment aspects of ARDS. So what is the important thing about this expiratory curve? You can clearly see there is a lot of difference between the inspiratory curve and the expiratory curve. And the expiratory curve is actually showing more compliance. So how can I tell the compliance is high in the expiratory curve? Because you can, one more easy strategy I will tell you is, like whenever the curve is closer to the x-axis, I can tell the compliance is going to be very less, because the unit change in volume, if it's closer to the x-axis, is going to be very less compared to the like unit change in pressure. So whenever the curve is closer to the y-axis, I can tell the compliance of this system is going to be very high, because like for unit change in pressure, the volume is going to increase dramatically. So that is why, like whenever the curve is closer to the y-axis, I can tell the compliance is very high. Similarly, you can see the expiratory curve follows something like this. So the inspiratory curve is here. So you can clearly see there is inspiratory curve is a little bit closer to the x-axis, and the expiratory curve is a little bit closer to the y-axis. So lung has more compliance compared to the lung in inspiration. So this phenomenon is what we call it as. So why this hysteresis happens in the first place? The reason is very simple, because the inspiratory curve is different from the expiratory curve. So that is why you get a difference. So why does inspiratory curve differs from expiration? Because the inspiratory curve is flat and is having low compliance, mainly because the initial surface tension, but expiration has like nothing to do with surface tension. So it's just going to collapse automatically because of the elastic recoil. So there is nothing to do with surface tension. That is why you get a difference between inspiration and expiration, and you get this hysteresis as a difference. And one more important thing is, you can see that, like I have kept a little bit gap, like during inspiratory and expiratory points. So this is a 0 point, and you can see clearly that this is the volume, isn't it? So the lung volume is never equal to 0, so only when you take the lungs out of the thorax in a dead body, your lung volume might become 0, but still the lung volume, the alveolar volume is never 0. It's always, you have some amount of volume that is left in the lung during a quite normal expiration, and that is what we refer to as something called functional residual capacity. Even though it varies with a lot of factors, but this FRC is quite important to maintain continuous oxygenation. So it depends on the number of alveoli as well. So obviously one of the important determinant of FRC is number of alveoli that is open. Normally itself, there can be some areas, especially when you are standing in the lower zones, the lowermost layer of the alveoli might be collapsed under gravity, but still majority of the alveoli are open under normal conditions. So the FRC is quite okay in the normal range. So what happens in a pathological, maybe a pathetic condition like ARDS? So what happens? So in ARDS, like let me draw a curve. First of all, if this is a 0 point, the FRC is going to be this. If this is the normal FRC, the FRC is going to be very, very less, because there is a lot of alveoli that are collapsed, or a lot of alveoli that are derecruited, and the number of functioning alveoli is going to be very less. So the FRC is going to be quite low. And because a lot of alveoli are closed, coupled with very little surfactant, and you have to give a tremendous pressure to open this collapsed alveoli, it's going to take a long time to open. So I can draw a curve something similar to this. So I can draw, this is the lower inflection point, and this somewhere here it's going to be the upper. Finally, what I'm coming to say is nothing but, since the ARDS, like the entire curve is closer to the x-axis, I can tell this ARDS lung is having very poor compliance, and it's going to be extremely low compliance, and it's very poorly compliant, and it takes a huge deal to open up the. And the next cool thing, what you're going to see from this diagram is you can see, for example, if you take this is the pressure of 5 centimeter of water, what you can clearly see is like at the same 5 centimeter of water, see the amount of volume the lung has, and at the same during inspiration, and for the same 5 centimeter of water, see the volume you're going to get in expiration. So which means the amount of volume you're going to achieve, lung volume you're going to achieve during expiration is quite high compared to what you're going to achieve during inspiration. And this is the entire idea of doing something called positive end expiratory pressure. So like in putting it in a simple way, like the lung is easier to, I mean, a lung is very difficult to expand initially, difficult to inflate. So, but once if it is inflated, it's easier to maintain the inflation, easier to maintain the inflation. So if you still don't understand, we can see very clearly see it in a much easier way. So let us assume this is the lung at 0 atmospheric pressure, probably at 0 centimeter of water. So let us see, like what happens in 5 centimeter of water during, let us say these are all happening during inspiration. So I'm applying a positive pressure during inspiration. So let us see what happens. Like you don't see a much, like change. Let us see what happens in 10 centimeter. Yes, it breaks the lower inflection point and the lung is going to expand a bit. So let us assume this is the volume that you're going to maintain at 10 centimeter of water during inspiration. And let us assume you are going to give 15 centimeter of water arbitrarily. So let us assume this is the lung you're going to get at 15 centimeter pressure. So you can see, okay, the lung has inflated. So let us assume the curves during expiration. Now the lung is going to exhale back. So let us assume now the pressure is reduced. And let us see what happens during expiration. Uh, at 10 centimeter of water. What you're essentially seeing at the same 10 centimeter of water, like the lung, the lung tends to maintain its volume, what is supposed to be maintained at 15 centimeter of water during inspiration. And when you reduce the pressure to 5 centimeter of water, see again the lung tends to be much bigger compared to what is happening during inspiration, which means what I'm trying to tell is if you apply pressure during this, these are the expiratory limbs. So if you apply the pressure during inspiration, it's very difficult to expand the lung. So, but once this expansion is achieved, it's very easier to maintain the volume during expiration. So that is the reason why the whole concept of PEEP is there, where we apply something called positive end expiratory pressure that keeps the lung open for a longer periods of time without. And next important thing, what I'm going to tell is something called ventilator associated lung injury. So remember, the ventilator associated lung injury is going to be, that's called ventilator induced lung injury. It's called VILI. So ventilator induced or ventilator associated lung injury, like it's going to be very severe in ARDS lungs again. So why? Because of the curve again. So you can see the curve. So you can draw the ARDS curve again at a normal curve. You can compare and see why this is the case. So let me draw, this is the like ARDS curve, and let me draw, this is the like normal lung. So what you can see is, let us see, this is the lower inflection point and this is the upper inflection point. And ARDS, this is going to be the lower inflection point and this is going to be the upper inflection point. So like what really happens? So below this level, so I'm going to call it as, this is the place where this zone up to the lower inflection point, we call it as zone of recruitment. So this is the place where when you apply the pressure, the alveoli tends to open. So this is the place where the alveoli are trying to open up. So that's why we call it as zone of recruitment. And beyond this upper inflection point, I'm going to call this as zone of overinflation. Because beyond this point, again, alveoli is not that compliant because you're tending to overinflate the alveoli beyond this point. So the ideal zone for alveolar ventilation without inducing any trauma is between the upper and the lower inflection point. So that is why I told you this is the most ideal region where you can ventilate the lung. So between the upper and the lower inflection point. So what happens in ARDS? So for example, when you are ventilating the lung, so there is no other treatment in ARDS. See, whenever you have a case of ARDS, intubate. That's it. No role for NIV, absolutely no role for non-invasive ventilation, mask ventilation, nothing. Just intubate the patient the moment you diagnose ARDS. So the ventilator strategies are quite important. So one of the important ventilator strategies you give is low tidal volume ventilation. So why you give low tidal volume ventilation? So let us assume what will happen if you give a normal tidal volume. So let us see here. This is a normal tidal volume. For example, you can argue that this is a volume, this is the pressure curve. So if you, this is a normal curve, so you are giving a normal volume, so which is not over distending for a normal alveoli or a normal lung. But the same amount of volume, if you give, you can clearly see like it's beyond the upper inflection point, and it's going to actually over distend an ARDS alveoli. So to avoid this high volume induced, so we tend to call it as volutrauma. So whenever you give a high volume ventilation, it's going to cause something called volutrauma to the ARDS lung. To avoid this, definitely have to give a low tidal volume ventilation, and absolutely it's a grade A or grade 1, whatever you call it as. It's a first degree recommendation, first class recommendation. You should not give high tidal volumes in ARDS. So it's going to induce severe injury in ARDS lung because of the compliance curve. And the normal tidal volume you give in the ventilator is somewhere around 8 to 10 ml per kilogram. It varies, but still this is what we follow. But never do that in ARDS. In ARDS, you're going to give somewhere around 4 to 6 ml per kilogram. So 4 to 6 ml per kilogram is the ideal one. Obviously, whenever you reduce the tidal volume, it's going to increase your partial pressure of carbon dioxide, because like the elimination of carbon dioxide is totally dependent on like ventilatory rate. So the respiratory rate is one of the major dependent, and the amount of ventilation is going to be a major dependent for like uh, elimination of carbon dioxide. So the moment you reduce the tidal volume in ARDS, is going to increase the PaCO2. Okay, that's acceptable, and that's what we call it as permissive hypercapnia. So that's what we call it as permissive hypercapnia. It's okay, it's fine, even though you have like a little bit of hypercapnia, a little bit of increased PaCO2 because courtesy to the low tidal volume, but still that's fine, that's okay. So the next strategy is going to be on the PEEP. So many people will be thinking that like that PEEP is very important. ARDS should always be having higher PEEP. Actually, it's not. It's quite not true. Actually, you have a lot of titration strategies for how much PEEP you should give. But an ideal starting PEEP is around 5 centimeter of water. That's what we do, and that's what like we actually follow something called ARDS network guidelines. So that's called ARDSnet. That's what we call in a short form. So this is what the guidelines we follow, and like this is the starting PEEP. Then and starting FaO2, as I usually mention, it should be always 100%, which you can down titrate later on. This is the starting FaO2 in case of ARDS lung. So tidal volume you are going to set at 4 to 6 ml per kilogram, not more than that in ARDS. And what about like other traumas, other types of traumas in ARDS? So first type of trauma I told you, volutrauma. If you set a high, tidal volume is going to definitely cause volutrauma and so much injury to the ARDS lung. And second thing we call it as barotrauma. So what do you mean by barotrauma? Barotrauma is nothing but it is due to increased transpulmonary pressure. So whenever the ARDS lung is going to have high transpulmonary pressure, it's going to have like you're going to get something called barotrauma. So this barotrauma can cause a lot of nuisance. It can cause ventilator-induced pneumothorax. It can cause something called ventilator-induced pneumomediastinum. Like it can cause a lot of complications. So this barotrauma has to be avoided. So what is transpulmonary pressure, by the way? So transpulmonary pressure. So if you take an alveoli, again for that matters, let me draw the pleura, surrounding pleura around the alveoli. So what is transpulmonary pressure? So let us assume this is AW. When I put PAW is the pressure of the airways. Under normal circumstance, in normal during expiration, the PAW is equal to 0. It is equal to atmospheric pressure. That's what. There's no pressure difference between the atmosphere and the alveoli. That's what I'm trying to tell. And normally, like either during inspiration or either during expiration, the pleural pressure, which I am going to call it as pressure of the PL, that is pleura, it's always negative. Normally the pressure of the pleura during expiration is about a negative of maybe like -1 to -2. So that's what it is. So what is transpulmonary pressure? Whenever there is a transpulmonary pressure, and like it is nothing but a difference between the airway pressure and the pleural pressure. So under normal circumstances, airway pressure is 0. During a tidal expiration, airway pressure is 0. So minus of, let us take -2, it's going to be +2 millimeters of mercury. So TPP should always be positive. So why? Because this TPP is nothing but the pressure that is needed to like prevent the alveolar collapse or to keep the alveoli open. So that's what you mean by a transpulmonary pressure. So it should always be a positive of, in a positive value, maybe +2 or +1. But once the like TPP becomes negative, the alveoli tends to collapse. So that's what happens in, like pleural effusion. For example, if the pleural pressure becomes positive in pleural effusion or in pneumothorax because of the fluid accumulation of the air accumulation, so the TPP tends to be negative. That is why a segment of a particular portion of the lung tends to collapse. Same thing happens in ARDS. In ARDS, because there's a lot of, like inflammatory fluid in this area, and the alveoli tends to collapse. Coupled with collapse tend to be even more severe in case of ARDS. So how can the TPP increase in ARDS? Purely because of our ventilator strategies. So because there are so many things in ventilator, for example, you are giving a positive pressure ventilation, which definitely is going to increase the transpulmonary pressure. So this ARDS lung is going to be under tremendous risk of going to get into for barotrauma as well, which we might be discussing in a different. Next thing, we see a new type of trauma called atelector trauma. For that, we'll see the original curve. So what you can compare these two curves, you can see one thing in this curve that like a normal lung has a little bit of more a lot of alveoli. Almost all alveoli are open during like at the end of normal expression. But in ARDS lung, at the end of expression, the amount of alveoli is very less. That's why I told you FRC is going to be very low. So during expiration, the amount of alveolar collapse at the end of expiration is going to be too high in case of ARDS. So it's very difficult to open up the alveoli again as well in case of ARDS compared to the normal lung. So that is the reason I told you why you're applying a positive end expiratory pressure. If you apply a end expiratory pressure at this point, you keep the lung open. This is called open lung strategy. Like you keep the lung open all the time by applying something called PEEP. That's applying to something called positive end expiratory pressure. So what is atelector trauma? So if you do not apply a PEEP, for example, so what happens? So the lung comes back and there is a whole lot of alveoli that's going to collapse during expiration. And again, you're going to inflate with the alveoli is going to open, and again you're going to deflate. So like the alveoli under normal circumstances, let us see in a diagrammatic way, so that's more better. So let us see under normal circumstances. This is the alveoli. Normally it is open and it's going to distend during inspiration. When you are going to apply some pressure, it's going to distend. But in ARDS, it's going to be something quite different. The alveoli is completely closed. It's collapsed. And you're going to open it again by applying a positive pressure. So you're going to distend it when you're applying a positive pressure every time. So the moment you like lose the positive pressure again, you come back to the closed state, which means like there is a shear stress which is getting created because of the continuous closure and opening of the lung, continuous closure and opening of the lung. And this type of trauma is what we called as atelector trauma. So, and that is the reason why it is very, very important that you have to apply a PEEP, positive end expiratory pressure, keep the alveoli as much as open as possible, and and try to ventilate in this zone, which is like a perfect zone for ventilation. So this is what we call as atelector trauma. So three type of trauma I told you. One is barotrauma, second is volume trauma, and the third one is called atelector trauma in ARDS. So how to ventilate? So what are the other strategies of ventilation? So like currently, recently there are a lot of strategies have come. The one of the most important strategies is prone ventilation. And if you tell a lot of standard books, they would have given us grade C recommendation, which is okay, average sort of thing. You can do it. But as far as the recent trials are concerned, this prone ventilation plays a very, very important. So what is prone ventilation? You give, like 16 to 18 hours of prone position. Remember, it should be continuous and consecutive. You should not like it's a total duration. You have to be continuously and consecutively make the patient prone for almost 16 to 18 hours. And maybe around 6 to 8 hours, you can put the patient back in supine position. That's what we call it as prone ventilation. So why this prone ventilation is quite important and how it works. So for example, again, when you see the patient in bed and if you take, this is the thorax, so the lung, like I don't know how to imagine, but still normally under research conditions, they quite imagine the lung like a cone. You can clearly see the base, the apex of the cone is going to be very thin and the base of the cone is going to be like little bit, like huge. So you see a lot of alveoli are present in the, like a lower surface in the posterior zones compared to the anterior zones. So what really happens is, since ARDS predominantly is going to affect I told you the dependent areas, and the place where you have a lot of alveoli in the lung are actually collapsed. So that is the idea of prone. So when you put the patient in prone position, so what's going to happen is you're going to make the lung something similar to this. So like now the lung is going to become like this. So you are actually putting a lot of alveoli, like up so that they move on to the non-dependent areas so that you are going to open up, like a lot of alveoli. So what you are essentially causing is something called alveolar recruitment. So you are increasing the alveolar recruitment during. There are a whole lot of trials which prove that clearly prone ventilation reduces mortality by at least 16 to 20%. But so I think your literature will change in the next edition textbooks probably. So currently, even though the textbook give grades evidence, as far as you know, that's one of the biggest things. And next thing, what you're going to do is like certain essential things like like as much as possible maintain a correct fluid balance. Do not have fluid overload. So fluid balance should be perfect, and no fluid overload, because the more you give fluid, more it's going to exit and more it's going to cause diffuse alveolar damage. So no fluid overload. That's another important strategy. And neuromuscular blockade, at least for the initial 48 hours, which means a full neuromuscular blockade. Like you have to, if possible, you can see a train of four response, like absolutely full neuromuscular blockade. That's what you are going to achieve. Because why this is important? Because again, one of the reason for getting trauma to the lungs in ARDS is ventilator patient dysynchrony. So ventilator patient dysynchrony, which is going to increase a whole lot of pressures in the lung, and it's like it's not good. It's not quite good. So to avoid ventilator patient dysynchrony, put the patient in full neuromuscular blockade. So let us discuss the strategies again in ARDS. Number one, first you're going to give low tidal volume ventilation. Second, put the patient in complete neuromuscular blockade at least for a minimum of 48 hours. And these are grade evidences, absolutely important, and they are going to reduce the trauma like anything. Number three, like PEEP, very, very important. I'm not telling it's not all important, very important. Like start at 5 centimeter of water, but you can increase PEEP based on a lot of tables. A lot of derivatives are there which is not needed for your level, so you have a whole lot of PEEP. So next thing, maintain fluid balance, avoid fluid overload. Fluid overload should be avoided as much as possible. And number five, I can tell something called prone ventilation. So these are the some of the important strategies that you follow in ARDS. And finally, last but not the least, there are certain things called ECMO. That's called extracorporeal membrane oxygenation. And I think I can discuss a whole lot of video in separate thing on ECMO and other ventilator strategies later on. But still, ECMO, you have two types: venous, arterial. Let us leave it. It's extracorporeal, where you take the blood out and oxygenate through a different chamber and remove carbon dioxide and leave it back into the body, into the circulatory system. So the benefit of ECMO is right now unclear, even though it looks very attractive, but still the benefit is not clear. So ECMO can be done only in severely refractory cases where you are not able to achieve proper oxygenation and the PO2 is persistently very low. PO2 F8 ratio is still less than 100. You have tried everything, you can possibly try ECMO. And other ventilatory strategies like high frequency oscillatory ventilation or high frequency jet ventilation, absolutely, a lot of recent trials have proved to have high mortality through this technique. So you do not do that. Even though it looks quite attractive, all these things, if I explain, because the entire idea of HFOV is to ventilate in the safe zone, that is between the upper infection point, lower infection point. But still, even though it looked attractive at the beginning, but still it showed high mortality or at least no mortality or no survival benefit. That's why we do not follow HFOV now. And one more interesting thing is, previously older guys used to tell that there's something called inverse IE ratio. So that during normal this thing IE ratio during normal circumstances in a normal, and persons who are breathing, is somewhere around 1:2, where the expiration is little bit more than the inspiratory limb. But what happens in when you are doing a physical exercise and when you are doing some exercise sort of thing, it becomes 1:1. So the IE ratio becomes 1:1 during exercise. So you're increasing the ventilation. So what happens next? For example, in conditions like bronchial asthma, so your IE ratio becomes somewhere between 1:3 or 1:4. What I mean is essentially it's prolonged compared to the normal. So that's what you're going to happen in bronchial asthma. Because of the obstruction, you have to expire a little bit more. So that's why in bronchial asthma, it's having more IE ratio. But what is inverse IE ratio? So inverse IE ratio is meant as you are prolonging the inspiratory time and reducing the expiratory time. So when you give a ratio of 2:1, that's what we call inverse IE ratio. Even though again it looked quite attractive because you are giving more time for inspiration and you're giving less time for inspiration, it's potentially dangerous and it's going to increase the trauma to the lung. And currently we never follow this inverse IE ratio strategies. And also there is a phenomenon called auto PEEP. It increases something called auto positive index expiratory pressure, which is going to be increased when you are going to reduce the time of expiration. So again, auto PP is a different topic for a different day. And these are the strategies I'm going to. So give a low tidal volume, 4 to 6 ml per kilogram. Number one, give a complete neuromuscular blockade. Give a little bit of PEEP, starting PEEP of 5, and later you can titrate it based on a lot of other variables, which you can discuss later on again. And do not give any fluid overload. Try to avoid fluid overload as much as possible. Try prone ventilation. It really works, man. And for refractory cases, you have another option like ECMO. And do not do things like HFOV and no inverse IE ratio ventilation. So this is what I'm going to this week's Dr. Dilip's MS Weekly is all about, and I hope you got it. I mean, this is a little bit relatively tough topic, and I tried my best to explain as much as possible, and hope you see in a different case next time. Thank